Hello, this is the lecture on organ and tissue donation and transplantation. This will be an adjunct to your classroom lecture time. Here are the objectives for our lecture today. We are going to look at information that is related to issues about organ shortage, the process for donation. We're going to discuss brain death, some of the diagnostic exams that go along with brain death. We can talk about your personal values related to organ donation, the principles of transplantation medicine, and then the nursing care of the transplant patient for various different organ transplants. So let's talk about the donor. How do we get organ or tissue donors? You can have living donors that are related to you or non-related. You may have heard of some of it's usually the kidney donation chains where I might need a kidney transplant, but nobody that is related to me and compatible to me is available. Likewise, someone else may need a kidney and someone that they may be related to or they know might be compatible to me. So it's like a chain. People donate to someone else and then somebody that person knows may donate back. So this is a great way to have kidney transplants. There are also donors who die of brain death. So these are patients that their death has been declared. They are brain dead, which is dead, and declared based on their neurologic criteria. And we're going to talk about that later on in the lecture. This is the majority of how we get our cadaver donors. And donation of patients who die of brain death means that they have a cessation of all brain and brainstem function. You can retrieve tissues and organs from these types of patients. Some of the causes are trauma, stroke, anoxia, and we'll talk a little bit more about that. There are strict laws and protocols that govern this type of donation. Every death is reportable to the local organ procurement agencies, and we'll also talk a little bit more about that. In addition to donation from a brain dead patient, you can also have donation after cardiac death. So this is when an irreversible brain injury has occurred, but the patient right now is not brain dead and possibly may not move to brain death, but they have an irreversible brain injury that they will not survive from. This is also called a non-heart beating donor. So these are patients that they've suffered devastating neurologic injury. They've had either head trauma. You can have anoxic injuries such as from drowning, some overdose patients. You can have a severe intracranial bleed. So the patient has this devastating neuro injury, but they are not brain dead. However, they can't breathe without the ventilator. They might need some vasopressor support, but they are not meeting the brain death criteria, which we're going to talk about later on. Lack of all your reflexes, lack of any brain or brainstem activity. And the family would like to withdraw support. Let me go back here. Sorry about that. I was trying to move this. Okay. If the heart is likely to stop beating within 60 minutes of the family withdrawing support, that is the patient that you can have the donation after cardiac death, and they can donate some organs and their tissues. So these patients, how it works, the family has decided to withdraw support. Then the organ procurement team would give them the option, if they would like, to donate their loved ones' organs, and usually they're the kidneys, and then other tissues. And we'll talk about tissues as well later. So if the family decides, then yes, they would like to do that. The patient goes to the operating room and is essentially prepared for the donation. And then the support is withdrawn, the patient is extubated, their vasopressors are stopped, or whatever support they were receiving. The family is allowed to stay there. And once the patient passes away, the family is given a few minutes then to say their final goodbyes. And then after the family leaves, quickly the OR teams come in to harvest the organs that they can get, which are typically the kidneys in this situation. Because as you can imagine, once all the support is withdrawn, the perfusion of the organs, the oxygenation has not been at its best level. So usually it's kidneys and then the other tissues that we're going to talk about. So types of illnesses or injuries that a patient can have resulting in a non-recoverable brain injury. Head injury, and we talked about those in the traumatic brain injury module. Patient that has had a devastating stroke or bleed, a primary brain tumor, and then conditions that cause anoxia. So drownings, smoke inhalation, prolonged cardiac arrest, and like I said, often overdose patients fall into this category as well. There is a severe donor shortage, and our representative from the Organ Procurement Agency will talk about how many people are living and waiting for different types of organs. Some of the solutions are that there are laws now that all deaths are reportable to the Organ Procurement Agency. So if you ever participate in care after a patient's death in the hospital, it doesn't matter what the death was from. Everybody is reported to the Organ Procurement Agency. And then they can speak with the family and see if the family wants any tissue donated. Also, requests for donations have been made now only by the OPO. So if you're in the situation where the patient is brain dead, the Organ Procurement Agency personnel, they are the ones who are trained and they know the best way to go about speaking with the family to ask them for if their loved one would like to be a donor. So that has helped to increase some of the donations as well. There are a lot of studies about that, and I'm sure our agency rep will talk to you about that in class. There are joint commission requirements, again, that every patient, every death has to be reported to the Organ Procurement Agency. There's increased public awareness. Donor registry, when you go to get your driver's license, they ask you there if you want to be an organ donor, and a lot more public awareness as far as commercials and different shows and things like that. Expanded donors. So we'll talk about, they've expanded the age, the pre-existing diseases that are allowed to donate. And then also in that same line, there's been an expansion of who can and cannot donate. Some of the myths surrounding organ donation are, and you probably have heard these, and maybe some of you think of this yourself, I'm too old or too sick to donate. Again, the age has been pretty much unlimited. It really depends on the patient now. So there used to be a top age, but now that's no longer true. Only the wealthy receive transplants. In the United States, there are strict rules and laws that govern transplantation. There's a list that people go on, and it's according to the list and how sick you are and how long you've been on the list, and different criteria such as that as far as who will get the transplants. And that's something that you can ask our Organ Procurement Agency representative when she comes in. You can talk to her about what are some of the criteria and people, how they're on the list and how they rank. Another myth, physicians and nurses won't save me. That's absolutely not true. If you've been involved at all in any type of organ procurement, physicians and nurses work very hard to take care of patients, even once we know that they may be a donor, because then even though we weren't able to save that person's life, we might be able to save many other lives by allowing for that donation if the family decides to give that gift. Donation will disfigure my body. Any type of organ procurement, it's typically a midline incision, which would be covered by clothes. If they are going to take any skin or tissue or bone, skin would come off the back. Long bones, they will put a prosthetic in. So there is no disfigurement. I won't be able to have an open casket. So yes, nothing from organ donation would preclude them from having an open casket. My family will have to pay for donation. Once the family has decided to offer the gift of organ donation, everything is paid for by the organ procurement agency. The family has no bills related to the donation. And my religion doesn't support donation. That is not true. Most major religions have no rules against organ donation. Some of the expanded donor criteria, which I talked a little bit about, no upper age limits. It really depends on the patient's health. Comorbid factors, even if the patient has a history of diabetes or hypertension. Sometimes if that has caused end organ damage, that might preclude them. But everything is looked at to see how healthy the organ is. If the patient has positive serology, so in the past, Hep B, Hep C, HIV have been things that would, not allow a patient to donate. But now, as long as the recipient is aware, for example, now there may be Hep C positive donor to Hep C positive recipient. One semester we had a recipient it was a liver recipient, and he received a liver from a Hep C positive person. But he was, he got the match. He was made the offer, and he was most likely going to die very soon if he didn't take that organ. So he was treated for the Hep C, which is very treatable now, and he took that organ. And also there's been a lot of leeway and, studies going into, again, HIV positive to HIV patients. So that has helped to expand the donors, the donor availability. And then also the donation after cardiac death, as we talked about. That's another way that a patient can donate. So let's talk about triage for patient death. So a patient that has cardiorespiratory death, so they have a loss of cardiac function or a loss of respiratory function. They can be a potential tissue donor. Let me see if I can get this off of the screen here. Sorry about that. So the tissues that are available to be donated are your corneas, so able to give someone sight, heart valves for transplant, skin. For example, skin they may use for burn patients. Long bones, often they'll take the long bones and they can grind those up for orthopedic surgeries. Often for back surgeries, they use the ground up bone to fix, some of the vertebrae. If people have fractures, in cases of tumors, they can use long bone transfer. And then saphenous veins also can be used for patients for open heart surgery. If you have a patient that has a non-recoverable brain injury, so they're ventilator dependent, these are the patients that are going to move to brain death. So if they have an irreversible loss of all brainstem and brain function, and they do not have a metabolic or anything inhibiting them pharmacologically, or if the family is discussing that they're going to withdraw the life-sustaining measures, which is the ventilator, sometimes vasopressor, sustenance. These are the patients that are potential organ and tissue donors. So the organs that can be recovered are your heart, your lungs, your liver, pancreas, intestines. Often pancreas and intestines will go together. So as I talked about some of the transplantable organs and tissues. So let's just do the tissues. Again, the corneas, the lens of the eye is transplanted, and this provides sight for those that have corneal disease. Skin go to burn victims. I spoke about the bone going for orthopedics or for a loss of a limb. Heart valve, mostly to replace heart valves in children. And then again, the saphenous veins, and we discussed the organs. So one organ and tissue donor can save or better the life of over 70 people. This is pretty amazing. So when you look here from one life-saving gift, one donor, the possibility are all of these things being donated and going out to many, many people, especially when you're talking about skin, bones, corneas, that goes to two different people. The bone can go to many, many people because they can grind it down. The skin can go to many people. So it really, truly is a gift. Let's talk about the patient with irreversible brain injury and what comes next. Let's talk about the brainstem assessment. So if you have a patient with the irreversible brain injury and you are looking at the determination of brain death, to do any of the brain death assessment studies, your patient needs to be basically in the best physiologic condition that they can be. So they need to be absent of hypothermia. Remember in the emergency module, we talked about you can't be cold and dead. So you wouldn't want to assess a hypothermic patient for brain death because they might have some loss of reflexes, obviously with severe hypothermia. They also need to be absent of any drug intoxication or a pharmacologic reason why their reflexes or the brainstem activity would be depressed. You want to support your patient toward hemodynamic stability. So if possible, get them as normothermic as possible, have their blood pressure be as normal as possible, and try and have a stable patient. Your clinical exam, you're looking at the patient's reflexes. And to determine brain death by neurologic criteria, the patient would be absent of all of their reflexes. So the reflexes such as pupillary reflex, are their pupils able to dilate and constrict? The corneal reflex, the oculocephalic, we talked about that in traumatic brain injury module. That's where if you turn the patient's head quickly, in a patient with an intact brainstem, the eyes would, if you turn towards the right, the eyes would kind of move towards the left. But in a patient that's absent their reflexes and absent that oculocephalic reflex, the eyes would stay straight forward, kind of like painted on doll's eyes when you turn the head. The oculovestibular, the cold caloric, that's where you shoot the cold fluid, usually it's cold saline, into the patient's ear canal. And if the patient has an intact brainstem, their eyes would deviate towards the side of the cold installation, and then they would have nystagmus. So a brain dead patient would be absent of that reflex. Absent of a cough or a gag. They would not have any response to painful stimuli. All of that would be negative, and they would have no spontaneous respirations, and you can test that with apnea testing. So to test for apnea testing, think about, why do we breathe? Our brainstem is triggered to breathe as our CO2 rises. So you're looking for the patient that has the brain injury to see if their brainstem will be triggered by a rise in carbon dioxide. So to prepare for this test, you want to stabilize the patient as much as possible. They can't start in an unstable situation, because once you take them off the ventilator to see if they're going to breathe, if they're unstable to begin with, they're just going to become rapidly more unstable, and you can't have that. So you want to start them off in as stable of a patient as you can. So sometimes this test isn't able to be done because these patients are typically very unstable. So stabilize the body temperature as much as possible. You can use heating blankets, warm fluids, heat lamps, whatever you can, because you don't want that hypothermia to suppress any brain activity that you're actually looking for. So you want to normalize the CO2, so between 35 to 45. We know that a rise in our CO2 should trigger our brainstem to breathe. So the patient will be on the ventilator. We're going to titrate down the rate of ventilation for this patient, and attempt to make them normocarbic before you start the test. You would do a baseline arterial blood gas in order to make sure that the CO2 was in a normal range. Also, you want to maintain adequate circulatory volume. I already talked about that a little bit. Try and get the blood pressure into a stable range. You would use fluids, blood products, whatever you need to get that blood pressure up. And then you're going to administer oxygen 100% for greater than 10 minutes. You want to get that PO2 up greater than 200, because you're going to be taking the ventilator off of the patient, and you're just going to be giving them oxygen through a little nasal cannula down through the tube. So you want to start them in a high oxygenation area so that their FiO2 is high for a while to get their PO2 up. So then the apnea test is done with the respiratory therapist and the registered nurse. So once all the preparatory steps are taken, you do your confirmatory blood gas to start the exam. Then you're going to remove the ventilator, and you're going to put between 6 and 12 liters of O2. They just put like a little cannula down into the endo tube to allow for oxygen down through the tube. You're going to monitor the patient for spontaneous respirations. The nurse will also be obtaining serial blood gases until the patient's PCO2 is greater than 60. Once the patient's CO2 is 60, the patient should have taken a breath if they have an intact brainstem. So lack of any respiratory effort with an elevated PCO2 indicates that the patient is brain dead, which is death. You would return the patient to the ventilator and renormalize their ABGs. Now, if during this time when you're doing your serial ABGs, and even if the CO2 has not reached 60, if the patient becomes unstable, so hypotensive, if they start to have arrhythmias or any other hemodynamic decline, excuse me, you would then stop the test and put the patient back on the ventilator and try and normalize their ABGs again, and you consider another confirmatory test. Again, once this test is done, and if you're able to complete it, and once that CO2 is up greater than 60 and the patient does not have a respiratory effort, this is a confirmatory test, and the patient can be confirmed that they are dead at that time. So some of the other confirmatory tests, like I said, sometimes these patients aren't stable enough to do an apnea test. So you may have to take them for a cerebral blood flow study. This is one of the most frequent done. This is a nuclear study that actually you can see if the blood flow goes up into the brain. And I think I have a slide of that, which I'll show you. A 4-vessel angiography. Again, you can see if there is actual blood flow to the brain. If the patient has herniated and they are brain deaf, there is no longer any blood flow to the brain. So you can see that on the angio. You can also do an EEG, which obviously would show no brain activity, a Doppler sonography, which that can also show if there's any flow to the brain. And then the Bayer testing is auditory evoked responses. And these are, this is not used very often, but it's how the brain processes sound. But these are just some other confirmatory exams. So here's a normal brain on the left. You can see that, there's some space in here. This is that edematous, swollen, enlarged brain. So since you're in that enclosed cranial vault and there was nowhere for this brain tissue to go, as the brain swelled, it pushed down through the foramen magnum. So your brainstem pushed down, and this is called herniation, which leads to brain death. So here's the picture of the cerebral blood flow study. You can see they also call it the hot nose sign. So if this is the patient's head, here's the brain, which is all dark. So all of this that is lit up, that's the radioisotope. So that should be up into the brain if the brain had flow. So with this darkened area, you can see that all the flow stops as it goes up, and there's no flow to the brain at all. This is a confirmatory exam, which means that the patient is brain dead. These are just some communication guidelines that we can use when you're communicating with family of potential organ donors. As the nurse, obviously you're communicating with them constantly, offering a large amount of support. You want to be very honest with them. You want to describe things in a way that the patient can understand, sometimes with, very simple instruction, but try and get them to understand, the gravity of the situation. So, your loved one has suffered severe damage to the brain, and that we're doing everything that we can, but she may not recover. So you would tell them some of the things that we're doing. Are we using 3% normal saline, trying to, get the fluid off the brain? Have you given any medications to try and, again, get that fluid from the brain? They're on the ventilator, so we're supporting their breathing. Do they have any vasopressors going? So, the patient, without the medication that we're giving them, they would not be able to have a blood pressure. What are all of the things that we are doing to help the patient? Has the patient gone for any type of surgery? Any brain surgery to relieve pressure on the brain. So, describe all of that to your family members in a way that they can understand it. So as things are moving and the situation is bad, you again, at a period of time, you would be sure that you would tell them that everything we have done, but we've done everything that we can do. And again, listing all those things, but things are getting worse, and there is nothing more that we can do right now. So typically behind the scenes, when you know that you have a patient that has a severe brain injury, you call Gift of Life and notify them so that they can just come in and follow. They stay behind the scenes and just start to get some information. You also are supporting the family. So in addition to taking care of this critical patient, you're supporting the family because obviously they're in a terribly traumatic time. You can have the physicians show pictures of the CAT scan or the perfusion scan to help them understand the grave prognosis. And then once the patient, if you do, say you do the blood flow study or the apnea test, you would say, the patient appears to be dead as there's no brain function. And we've begun a series of studies to confirm this. We want to be extremely thorough and careful to ensure that we are absolutely correct. So you can go through the different studies if they've had an apnea test or they're going to have one, and what you would be looking for if the patient would have an intact brainstem. The angiography exam, the different reflex exams, you would tell them, you are looking for the patient to blink. For example, with a corneal, you're looking for them to blink. When you suction them, you're looking for the patient to have a gag. You can tell them about the oculovestibular. When you shoot cold water into that ear, you would expect that their eyes would move if they had an intact brainstem. So all of those simple things you can talk to the family about and get them to an understanding, wherever they are with it. And then once you do have the confirmatory test, the physician will, read the confirmatory test. They will document the time of death. And, the physician would tell the family that we finished the testing and found that your loved one has died, and they can give them a time if the family asks for the time. And as I said before, if possible, you can repeat some of the clinical exams when the family is there, so they can actually see that the patient had no reflexes. When you're giving them pain, they had no movement, and the pupils and the cough and all that I talked about a minute ago. And as you can imagine, this is a horrible time for the family. So you need to, be ready to support them if they would like chaplain services brought in. If a family member is there alone, is there anyone that you can call to have them supported? And just be ready to really support that family because they're receiving this terrible news. So once the patient is pronounced brain dead, then the patient is dead. So you really need to provide a consistent message at that time to the family. You don't want to give any conflicting messages. So you're not going to use terms like they are on life support, because we are no longer supporting life. The patient is now dead. So you're using the terms artificial support. And this is sometimes hard to do. We're all taught, you always talk to your patient, but in this instance, the patient is not in a coma anymore. They are now dead. So, say when you're going to suction, you don't have to tell the patient, okay, I'm going to suction you now and make you cough, because the patient is dead. So again, you're trying to get that message across to the family that the patient has passed and you are now only supporting the body right now. So care from the ICU team. This is really a coordinated effort with the physicians, respiratory therapy, and especially nursing. These patients are critically ill once they are declared brain dead. And then if they do go through with, then the organ procurement agency will talk with the family. Sometimes they need some time to make their decision. But, once the decision is made to donate, then a lot of things start to happen. So there are numerous exams to make sure that the organs are suitable for donation. So you may have to take the patient for a cardiac cath. There are different pulmonary function tests, so you may have to take them for a lung scan. There's a lot of lab work that is sent with serology to try and get the patient to see who's going to be compatible with them. The patients, based on herniation and this total circulatory collapse, the patients become very unstable. From the herniation, they also have hormonal depletion, which again causes severe hypotension. So patients often need a large amount of fluid and circulatory support. They also have a loss of their thyroid hormone, which causes severe hemodynamic instability. So often these patients are put on, it's called T4 protocol. And the T4 protocol, there's a few medications that are given, dextrose, corticosteroids, and then they're put on an infusion of levothyroxine. And this is to try and combat some of that hemodynamic instability and stabilize the patient out while you're preparing to actually send the patient for donation. And again, that extensive family support, because this is the worst of time for them. Let's talk about the organs that we can transplant. So heart transplant, and all of these links here that I have, when you are in the PowerPoint that's on the course, if you're in slideshow mode, you can click in on those links and see some of the videos that I have. So let's talk about a heart transplant. So obviously, patients are devastatingly ill when they need a heart transplant, and many patients die while they're waiting. But if they are lucky enough to receive that gift, they're going to have a surgical replacement with that donor heart. And in order to have the transplant, the patients need to be somewhat a comparable body weight and they need ABO compatibility. So you can imagine if it is a very large male patient, their heart would not be donated to a petite, small female patient. So typically, body weight size is considered. The heart is one of the organs that can be out of the body the least amount of times. So that needs to be transplanted within 4 to 6 hours of procurement. And post-op care is similar to that of post-op CABG patient. So you would take care of them the same way. You're going to monitor them for signs and symptoms of cardiac tamponade. So if you think about that, your muffled heart tones, your hypotension, that decrease in cardiac output. You're going to support cardiac function. And then as the patient, you're going to keep in mind as the nurse and the recipients need to be educated. Their transplanted heart is disconnected from the autonomic nervous system. So they don't have sympathetic and vagus nerve reactions to their heart. The sympathetic and the vagus nerves don't affect their heart. So they need gradual increase and decrease to get their heart either increased, they don't have that fight or flight. So they need a gradual increase and decrease when they exercise to get their heart up, and then again to bring their heart rate down. And these patients, atropine will not help. If they're bradycardic, atropine will not help that. You're going to do nursing interventions to prevent transplant rejection. And typically, let me move this away for you. The medications that are used for the transplant patients are the corticosteroids, the calcineurin inhibitors like tacrolimus, and the antiproliferatives. So preventing transplant rejection really is the key. Obviously, these patients have been given a great gift and we need to protect it. So the patients will need lifelong medication therapy. Some of the side effects of the medication therapy that I just spoke of can be hypertension, osteoporosis, skin cancer, weight gain, obesity, diabetes, and dyslipidemia. So even though the patient has their new heart, they still may be at risk for some of these side effects and diseases from their medications. Some signs and symptoms of that their heart, the transplant is being rejected. So the patient can become short of breath, fatigue. Some of the hallmark symptoms of heart transplant rejection is a fluid gain around the abdomen, abdominal bloating, a new onset of bradycardia, low blood pressure, dysrhythmias such as AFib or flutter, and the patient may have a decrease of activity tolerance. Once their ejection fraction is decreased, that's typically a later sign. And infection is the major cause of deaths in these patients. So aseptic technique, as always, is a key nursing intervention. So let's talk about the kidneys now. So as I talked about early on in this lecture, you can receive a kidney transplant either from a living donor that is related or not. You can have kidney from a non-heart beating cadaver donation after cardiac death, and then also kidney from brain death that we just spoke about. So psychosocial preparation is key. These patients may have been on dialysis for a long period of time. They may, it depends if you receive a kidney from a cadaver patient, and this goes for any transplant recipient, kidney, heart, lung, anything. There are instances where the recipients, they become depressed because they think that someone else had to die in order for them to receive their life-saving organ. So a lot of psychosocial preparation goes into any transplant recipient. The kidneys can last the longest out of the donor, and that's one of the reasons why they can be harvested at donation after cardiac death. The kidneys can last for up to 36 hours out of the donor. They're taken to the organ procurement agency and they're actually flushed, and they can sit and wait until they're implanted. There will be immunologic studies done, so tissue typing, human leukocyte antigens, lots of different immune studies that go so that they can be sure that the donor and recipient are a good match. The donor has to be the same blood type. So pre-op, the patient may need dialysis pre-op. You're trying to get them in as healthy a state as you can be. Also, they may receive a blood transfusion from the donor. And for the most part, you want your recipient to be infection-free, because you don't want to implant this new kidney and then you're going to hit them with all the immunosuppressants if they have a pre-existing infection. Kidney transplants are done by the physicians leave the diseased kidney in place. Typically, they are not removed. The diseased kidneys are kept there, and the new kidneys are kind of set in the front. So here's a schematic for you to see. So here's the transplanted kidney. Here's your bladder and the new ureter coming down here. Post-op kidney transplant, first and foremost, is you want to prevent infection. So aseptic technique all the time. Urologic management. Obviously, initially they're going to have a Foley catheter because you need to monitor that urine output hourly, at least for the first 48 hours. If there are no complications, then you want to get that Foley out as soon as possible, because as we know, having an indwelling Foley catheter increases your risk for infection. So you do need it early on to monitor how that new kidney is working. But you want to get that Foley out and do Foley care per protocol to decrease that chance for infection. Some of the complications from kidney transplant are complication of rejection, the acute tubular necrosis. So the tubules can become necrotic and the kidney can fail that way. Thrombosis, so there may be some clots. Renal artery stenosis, and then other complications and complications from immunosuppressant therapy. Some of the immunosuppressants. So the patients are typically on a combination of specific immunosuppressants, and then less specifics, and also corticosteroids. Cyclosporin is expensive. That one has probably the most side effects. They do use that though, and doses are adjusted to the patient. The tacrolimus, that suppresses your T cell actions. And then also these patients are given the monoclonal antibodies, which reduce T cell growth and activation. And some treatments that are under investigation are some cancer medications, therapy for cancer, and these are showing promise in trying to immunosuppress the recipient. Signs and symptoms of kidney rejection. So there's 3 different types of rejection. There's your hyperacute, which occurs pretty much immediately. So within the first 48 hours, the patient will show an increased temperature, they'll become hypertensive, and they have pain at that transplant site. The only treatment for the hyperacute is immediate removal of the transplanted kidney. Unfortunately, it hasn't worked and the kidney has to come out. You can have acute rejection, which can occur a few days after the transplant, up to a few months, and the kidney will start to fail. So they will either have small amount of urine or no urine at all. Their temperature and blood pressure can raise. Their kidney will enlarge, so it'll be tender. The patient may become lethargic. And as you might be able to think, their creatinine and their BUN will start to creep up because, again, the kidney isn't working, and they will start to retain fluid. The treatment here, you can increase the dose of immunosuppressant drugs, and often this can be reversible and the kidney can survive. Patients also can have chronic kidney rejection. So this occurs gradually over a period of months to years. So if you think of kidney failure, that's what this patient is going to look like. So a gradual increase in the BUN and creatinine. The patient will start to have the fluid retention, electrolyte abnormalities, as in any type of respiratory or renal failure, and fatigue. And the chronic can be treated conservatively and managed as any other renal dysfunction would until possibly dialysis might be required for the patient. Let's look at a liver transplant now. So liver transplant is removal of the diseased liver, and it can be replaced with a full liver from a cadaver donor, or you might have a live donor, which can give you a right lobe. So that is reserved often for patients that are very clearly close to death and might not get a transplant. So you can have a live donor just give part of their liver. Hep C is the most common reason for liver transplants. And the liver, once it's removed from the donor, can be preserved for about 8 hours after it comes out. And from a cadaver donor, you can have a split liver transplant, and that can be suitable for 2 patients. Sometimes they'll take the small lobe and give to a child, and then the larger other side they'll give to an adult. And then again, you can have the living donor transplant, and that's used for your patients with the highest potential for mortality while they're waiting. Complications associated with the liver transplant. You can have the acute graft rejection. That's usually in about the first week, about the 4th to the 10th post-op day. So some signs and symptoms that you would see with the liver transplantation if there's an acute graft rejection. Patient would be tachycardic, their temps would be up, they can have right upper quadrant pain. Think about if your liver is failing. So think about what are your signs. So again, right upper quadrant, because that's where your liver is. You would have diminished bile drainage because your liver isn't working. Jaundice because your liver isn't working. Increased serum bilirubins, transaminase, and your ALT phos, and also a prolonged PT. So all of the adverse effects from a liver in failure. To prevent this, the patients are given their immunosuppressant agents, cyclosporin, but again, side effects, cyclosporin has the most side effects, mostly nephrotoxicity, and there are other regimens of immunosuppressants that these patients might receive. Infection is the leading cause of death after a liver transplant, so some signs and symptoms would be a fever, foul smelling drainage, so that could be urine, if they have a wound, if they have any drainage, so foul smelling bile. To prevent this, you're going to use strict asepsis, which should be all the time. Prevent any CLABSI, which is your central line associated bloodstream infection. So if the patient is in the hospital, you're using protocol for your central lines. Ventilator-associated pneumonias if the patient is on the ventilator, and vigilant monitoring of these patients. Also, bleeding is another complication after liver transplantation. And this can be caused from coagulopathy, again, if the liver isn't working correctly. If the patient had portal hypertension prior to this liver transplant, they were ill prior, and from their liver not working beforehand, they have portal hypertension. So you can have fibrinolysis from your liver ischemia, and then hypertension is another complication, and that's typically managed with medication. Pancreas transplants. Pancreas transplants are typically done for patients who are extremely brittle diabetics. These are less common, the pancreas transplants, but they help those patients who have a difficult time treating their diabetes. And these also require lifelong immunosuppressant drug therapy. Any transplant requires your immunosuppressants. And the pancreas can be transplanted as a whole pancreas, or can go together. You can have a pancreas transplant after the patient has had a kidney transplant, or they can go together, pancreas and kidney. Because when you think about the diabetics, often your diabetes will lead to kidney disease. So often the patient who needs the new pancreas has also had some kidney disease, so they need both organs. It's much the same as the kidney, they leave the old pancreas in place and the new one is placed in the abdomen. And one of the newer transplantation things that have occurred are the islet cell transplantation. So they actually take the islet cells from a cadaver from the pancreas glands, and they inject them into the portal vein. The new cells come in and they lodge in the liver, and they should start to secrete insulin. So it's experimental, hasn't lasted long for the patients, but new treatments and therapies are occurring all the time. Some complications after a pancreas transplant. So you can have thrombosis. Again, there can be clots that come into any of the vessels leading in or within the organ itself. Pancreatitis, so the pancreas can become inflamed, and anastomosis leak. Some of the signs and symptoms that the nurse will be looking for would be a decrease in the urine output, an increase in their blood glucose, because again, that pancreas isn't working, hematuria, if there's tenderness at the graft site, and if their amylase increases and then stays up, that can also be a sign, symptom of pancreas transplant. Management of any transplant rejections, the patient needs to be on a maintenance therapy. It's that continuous immunosuppression because they received an organ transplant. So it's typically the combinations of medications. So specific immunosuppressants such as cyclosporin, and we already talked about the complications, the adverse reactions from that. But these include specific and effective suppression of the rejection. They are a lot of money, and they have major adverse reactions. The more, the less specific immunosuppressants, so like the Imuran and the Cellcept, and then corticosteroids. The tacrolimus also is used. That suppresses the T cell actions. And the tacrolimus, the immunosuppression is not as great as the specific immunosuppressants, and patients' risk for infection is less. So these are some of the medications to manage the transplant rejection. And these are some stories of patients who have received organs. Specifically, try and take a look at this one. This is a friend of mine and a local surgeon, and hopefully you'll enjoy these stories. I hope you learned something from this lecture, and I'm sure that you will definitely learn something from the class time when we have our representative from the Gift of Life there to answer questions and give you some more information. And we will also have a guest speaker, which will be either a donor family or a recipient of an organ. And that's information that you can't get out of a textbook. So come with some questions to ask both the organ procurement representative and also our guest speaker to get a firsthand account of organ donation and transplantation. And if you have any further questions, just be sure to bring them to class, and I'll be happy to answer anything for you.